Module 3, Lecture B, Rules and Validation. By the end of this lecture, you will be able to implement validation checks for missing, out-of-range, or inconsistent medical inputs, create rule-based clinical scores using conditionals, loops, and dictionaries, and report calculation results with warnings that clarify assumptions and limitations. Input validation checks, missing input checks. Clinical calculations are reliable only when all required information is present and usable. Because healthcare data may be missing, such as lab results or medication history, a validation check should happen before calculating. Without key inputs, results like kidney function or body mass index can appear precise but be wrong, so these checks help catch missing data before it causes errors. When validating clinical inputs, distinguish between information that is required, optional, or safely assumed only with a clear explanation. Missing data may be blank or marked as unknown, and those meanings should not be treated the same. For example, absent allergy or smoking information should not be interpreted as no allergies or non-smoking. Clear handling of missing inputs helps prevent unsafe assumptions and clinical errors. When required inputs are missing, a calculation should clearly guide the user instead of simply stopping. It should explain what information is missing, why it matters, and what is needed to continue. Critical data may require pausing the calculation, while less essential gaps may allow progress with a clear warning. This keeps the process transparent and reinforces that calculations support but do not replace informed judgment. Python code, missing input checks. This section demonstrates checks for missing clinical input. Required fields must be provided before calculations can proceed, and warnings should clearly explain any limits or uncertainty in the results. A small patient record is created with an age of 67 and a missing weight value. The missing weight is represented as none, so a later check in the script can detect that a required clinical input has not been recorded. The code records the patient's height as 170 centimeters for later calculations such as BMI. It also marks the patient's creatinine level as unknown, meaning that value is unavailable and should be treated as missing during validation. The program first defines common markers for missing data, such as no value, blank text, unknown, or not recorded, so invalid fields can be detected. It then identifies the required inputs for key calculations: age, weight, and height. Creatinine level is treated as optional because it is only needed for certain analyses. The process creates an empty list to track required patient fields that are missing. It checks each required field by looking up its value in the patient record, then compares that value with known missing markers such as none or unknown. Any matching field is added to the missing list, so later calculations can handle absent essential data appropriately. The code checks each patient record value against known missing markers. When a required value is missing, it records the field name so essential absent information can be flagged for follow-up. The code creates a list to track optional patient fields that are missing or invalid. It checks each optional field in the patient record and looks for predefined missing markers, such as none or unknown. Any field with a missing marker is added to the list so it can be handled later. The code checks whether a field's value matches any predefined marker for missing data. If it does, the field is recorded as a missing optional field, making it easier to see which optional data is unavailable for later analysis or calculations. The code prints a brief summary of input validation results. It reports whether any required or optional fields are missing, listing them when present, and saying none when all are provided. This gives a quick overview of data gaps before further calculations are performed. The code first checks whether the patient data includes all required fields. If anything is missing, it stops the body mass index calculation and prints a warning message. This prevents errors and avoids producing a misleading result from incomplete information. If all required fields are present, the code converts the patient's height from centimeters to meters, then calculates body mass index using weight and height. It prints the BMI rounded to 1 decimal place, with units of kilograms per square meter. The code calculates BMI by dividing the patient's weight in kilograms by their height in meters squared. It rounds the result to 1 decimal place and prints it with the unit kilograms per square meter, giving a clear BMI summary when the required data is available. The code checks whether any optional inputs are missing. If so, it warns that the kidney function interpretation may be incomplete, because these extra details can affect the accuracy or completeness of some clinical conclusions. The code displays a warning that clinical calculations need all required inputs to be complete. This reminds users that missing data can make results inaccurate or incomplete. So reliable calculations depend on providing the necessary information. The script checks a patient record for missing clinical information, separating required inputs such as age, weight, and height from optional data such as creatinine. It flags missing values and reports that weight is absent in this case. Because a required input is missing, it does not calculate body mass index. And if optional kidney-related data is missing, it warns that kidney function interpretation is incomplete. The main point is that accurate clinical calculations depend on complete required data. Range checks. Range checks make sure medical values fall within sensible limits before they are used in calculations or decisions. A value can be correctly formatted but still clearly wrong, such as a temperature or heart rate that is far beyond realistic human ranges. These checks are meant to catch obvious input or data capture errors and prevent misleading results, not to diagnose medical conditions. Clinical range checks must account for context, because acceptable values depend on the patient, measurement method, units, and intended use. A value that is abnormal for one patient group may be normal for another, and unit mistakes can make valid results seem unsafe. For measurements like weight, glucose, and height, range validation helps detect entries that are numeric but clinically implausible or inconsistent with calculation assumptions. Range checks should distinguish invalid values from unlikely or extreme but possible ones. Impossible entries, such as a negative age, should be blocked, while unusual readings may need user confirmation rather than automatic rejection. Clinically extreme values can still be real and important, so validation should use hard limits for invalid data and soft limits to prompt verification. Python code, range checks. Range checks help protect clinical calculations by catching unsafe or unrealistic inputs. Hard limits block values that are impossible, while soft limits warn users when values are unusually extreme. The validation setup stores expected ranges for adult patient measurements, such as age, height, and heart rate. Each measurement has hard limits for values that are physically possible and soft limits for values that are typical. Values outside the soft range are flagged as unusual, while values outside the hard range are treated as invalid. This helps check patient data and identify entries that may need closer review. The script begins with a small set of patient records each containing an identifier plus age, height, and heart rate. Some entries are valid, while others intentionally include errors, such as a negative age, a height entered in the wrong unit, and an unrealistically high heart rate. These mixed examples are used to test whether later range checking can detect invalid health data. The function takes a measurement name and value, then looks up that measurement's allowed limits. It first checks hard limits, which define the absolute possible range, and then soft limits, which define the usual range. This lets the function reject impossible values or flag values that are possible but unusual. The code first checks whether the value is missing or not numeric. If it is absent or not an integer or floating point number, the function blocks it and returns a message saying the field is missing or not numeric. This prevents invalid data from being processed further. The code checks whether a value is outside the allowed hard limits. If it is below the lower limit or above the upper limit, the value is blocked, and a message identifies the field and the invalid value. This prevents impossible values from continuing through processing. This code checks whether a measurement value is outside its defined soft limits. If the value is below the lower limit or above the upper limit, it returns a warning that the result is clinically unusual, including the measurement name and value. This helps flag atypical results that may need further review. When a value is within both the hard and soft limits, the function returns an OK status. It also creates a message saying the parameter and its value are accepted. This means the value is normal and can continue processing without warnings or blocks. For each patient, the process prepares to validate the record by creating a place to store validation messages and setting a block indicator to false. If any data value falls outside the hard limits, that indicator can be changed so the patient's record is blocked from further processing. For each patient, the code checks every defined field against its allowed range using the check range function. It records the returned message for review, and if any check reports a blocking status, it marks the patient as blocked. This ensures all patient data is validated consistently and that any blocking issue stops further processing. The code checks each patient for blocked values to decide whether processing should stop or continue. It also counts messages that mention unusual findings as warnings. For each patient, it prints a summary with the patient ID, the stop or continue decision, and the warning count. The code states a key validation assumption. Adult height values are recorded in centimeters. This matters because the validation logic must interpret the height data using the correct unit to avoid incorrect results. This script checks patient age, height, and heart rate against clinical range limits. Hard limits identify impossible values and stop the patient record, while soft limits flag unusual values with warnings but allow it to continue. The output reports each patient's status and warning count, and it depends on height being recorded in centimeters for accurate validation. Type checks. Type checks make sure medical data is in the right form before a system uses it in calculations. In clinical settings, this helps prevent mistakes by confirming that values like heart rates, birth dates, and medication names are treated as the correct kinds of data. By acting as a gatekeeper, type checking supports safer and more consistent interpretation of medical information. Clinical data often comes from different sources and formats, which can cause fields to contain the wrong kind of information. Type checks help catch problems early, such as values that should be numbers but are actually dates or text, before they affect calculations. They also clarify special cases, such as whether a symptom is absent, unknown, or described in detail. This helps systems interpret data accurately and flag cases that may need clinician review. Clinical systems need type checks that give clear, specific feedback so users can quickly correct input errors. They should identify the affected field, state what kind of value is expected, and avoid guessing from ambiguous text. This supports patient safety because incorrect data types can quietly change calculations, while proper checks improve reliability and prompt human review when needed. Python code type checks. Type checks help protect clinical calculations by making sure each input field matches what is expected. When something may be wrong, warnings prompt safer human review. A patient record dictionary is created to hold basic clinical data. It includes heart rate as the word 80, which is likely an error because heart rate should be numeric, and oxygen saturation as the number 98. This example sets up a check to make sure patient data types match what clinical calculations expect. The patient record stores symptom presence as the text value yes, which may cause a type mismatch if another type is expected later. The weight value is stored as 70.5 kilograms, a floating point number, which is appropriate for representing weight with precision. We use an expected types dictionary to define the required data type for each patient record field. Heart rate and oxygen saturation are both expected to be whole numbers. This helps confirm the data is in the right format before it is used in later calculations, reducing the chance of errors. The snippet defines the expected data types for two patient record fields. It treats symptom presence as a true or false value, and patient weight in kilograms as a decimal number. These type rules help ensure inputs match the required format, supporting reliable clinical calculations. We create two lists to track validation results, one for fields that pass the type checks, and another for warning messages about problems like missing fields or type mismatches. This keeps valid fields separate from issues that need attention. The code goes through each expected field and type, then retrieves the matching value from the patient record. This lets the program confirm that required data is present and has the correct type before it is used later. The code checks each needed patient record value to see whether it is missing. When a missing value is found, it adds a warning that identifies the field. This helps confirm required data is available before calculations continue. The code uses the instance function to check whether a value has the expected type. If it does not, it gets the value's actual type name and uses it to create a clear warning message. This makes type problems easier to identify and helps maintain data integrity. The code builds a warning message when a field has the wrong data type. It gets the expected type name, combines it with the field name, and adds the actual type that was received. This completed message is then stored in a list of warnings to inform the user about type mismatches. When a value has the expected type, its field name is added to the valid fields list. This means the field passed the type check and can move on to the next stage of processing. The code summarizes validation by showing which fields passed the data type check and how many warnings were found. This helps identify missing values or type mismatches and gives a quick sense of whether the data is ready for further processing. The code goes through each stored warning and prints it with a clear warning label. This helps users quickly see which patient record fields have problems and need attention. The code checks whether any warning messages were created. If there are none, it treats the data as ready, meaning all fields passed their type checks. It then prints whether the data is safe to use for further calculations. This script validates a patient record by checking that each field has the expected data type, such as numbers for vital signs and weight, or a true or false value for symptoms. It flags missing fields or type mismatches with warnings, then reports which fields are valid and how many issues were found. The data is considered ready for clinical calculations only when there are no warnings, helping prevent errors caused by inconsistent input types. Clinical rules scoring. Point-based rules. Point-based clinical rules turn patient observations into a clear score by assigning points to specific findings. The total score summarizes the combined importance of those findings and supports interpretation and decision-making. Because the rules are explicit and step-by-step, users can see how each criterion affects the result instead of receiving an unexplained number. Point-based clinical rules depend on clear conditions that determine when points are assigned, such as whether a value crosses a threshold. Cutoffs should be stated precisely, including whether the boundary value counts, to keep calculations consistent. Organizing categories and point values with dictionaries can make the rule easier to maintain, explain, and audit. Point-based clinical scores should treat missing or unclear inputs carefully. Missing data should not be assumed to mean zero. Instead, the system should mark the score as partial or warn the user. Any assumptions about diagnoses, medications, or care settings should be explicit, so users understand how the score was produced and how reliable it is. Python code. Point-based rules. Point rules make clinical scores easier to understand. Dictionaries keep score values organized, and validation helps prevent hidden assumptions from producing misleading results. A small patient data dictionary is created to store key health information. It includes the patient's age, 72, and body temperature, 38.6 degrees Celsius. This structure makes the data easy to access and use later in the code. The patient data records 3 key clinical signs: a respiratory rate of 24, systolic blood pressure of 88, and confusion. Together, these measurements are used to calculate a clinical score based on predefined rules. The patient data records oxygen saturation as missing and symptom severity as moderate. These values are stored with other patient information and will be used to calculate a clinical score, including severity-based points. A severity points dictionary assigns numerical scores to symptom severity levels, such as 0 for none and 1 for mild. This makes it easy to look up each severity level and add the correct points during scoring. A dictionary maps symptom severity levels to point values so they can be scored consistently. Moderate symptoms count for 2 points, while severe symptoms count for 3 points. The program uses this mapping to assign the right score based on a patient's reported severity. The process begins by setting up 3 starting pieces: a score to track accumulated points, a place to record the reasons points are added, and a place to note warnings about missing or problematic data. Together, these make the scoring transparent and help flag issues for review. The code first identifies the key numeric patient fields to check: age, temperature in Celsius, respiratory rate, and systolic blood pressure. It then loops through these required fields to confirm each one exists in the patient data, so missing values can be handled properly later. The code safely checks each required patient field and identifies any missing values. If a required value is absent, it adds a warning that names the missing field, helping ensure the scoring process has all necessary data. The assessment checks whether the patient is 65 or older, since this age group is considered higher risk. If so, 1 point is added to the score, and the age-related reason is recorded to explain how the score was calculated. If the patient's temperature is 38 degrees Celsius or higher, the score increases by 1 point. This indicates a clinically significant fever, and the temperature finding is recorded as a reason for adding that point. The code checks whether the patient's respiratory rate is above 22, using this as a cutoff for tachypnea or rapid breathing. If so, it adds 1 point to the overall score and records the reason, making the score calculation clear. The code checks whether the patient's systolic blood pressure is 90 or lower. If so, it adds 2 points to the score and records that low blood pressure was the reason, making the scoring process clear and traceable. The code checks whether the patient has new confusion. If so, it adds 2 points to the score and records the reason, making the scoring change clear and traceable. The code checks whether the patient's oxygen saturation value is missing. If it is not available, it adds a warning that the score is only partial, helping keep the scoring process transparent. The system retrieves the patient's symptom severity from their data, then checks whether that severity matches a predefined scoring category. If it does, the related point value is added to the overall score. This keeps the scoring consistent and based on established rules for each severity level. The code checks the patient's symptom severity and uses it to assign the matching number of points. If the severity is recognized, it records a reason explaining the severity and points awarded. If the category is not recognized, it adds a warning that the severity could not be found. The output first shows the patient's total score, then explains which rules contributed points by combining the reasons into one readable summary. It also reports any warnings or says there are none if no issues were found. Finally, it includes a disclaimer that the example is for education only and is not a validated clinical tool. This script estimates a patient's clinical status with a point-based score using measures such as age, temperature, breathing rate, blood pressure, confusion, and symptom severity. It adds points when predefined risk criteria are met, records the reasons for those points, and warns when missing data makes the score incomplete. The output is a total score with supporting explanations and any missing data warnings. It is only an educational example, not a validated clinical tool. Threshold logic. Threshold logic turns clinical measurements into decisions by comparing a value with a set cutoff, such as whether it is above, below, or within a boundary. It is often used in clinical scores to trigger actions based on measures like fever, oxygen level, or blood pressure. Because the meaning of a number depends on context, the same value may lead to different conclusions in different patient groups or settings. Accurate threshold logic therefore requires both correct comparisons and clinical context. When using threshold-based scoring, define each boundary clearly so every value has one interpretation. Specify whether exact cutoff values belong to the lower or higher risk group, and make sure ranges do not overlap or leave gaps. These boundary choices affect the accuracy and reliability of the score. Threshold logic compares conditions in a set order, using single cutoffs or multiple levels to guide decisions. The order matters because it determines which category is chosen and helps avoid incorrect early conclusions. These thresholds should be explained clearly, especially when they are screening signals rather than diagnoses. Used well, they make clinical reasoning more consistent and transparent while leaving final interpretation to the broader patient context. Python code, threshold logic. Threshold rules convert measurements into categories by using clear boundaries that avoid gaps or overlap. Warnings should also state the assumptions and clinical limits behind those categories. A dictionary stores example patient measurements for later threshold checks. It includes temperature in Celsius, oxygen saturation percentage, and systolic blood pressure in millimeters of mercury, using the values 38.2, 91, and 88. A rules dictionary stores warning thresholds for patient measurements such as temperature, oxygen saturation, and systolic blood pressure. It flags high temperature as a possible fever and low oxygen saturation or low systolic pressure as potential concerns. This makes it easy to compare patient values with preset limits and generate the right warning. The process begins by setting up two containers for evaluation. One to count how many patient measurements meet threshold rules, and another to collect any warning messages. These prepare the system to track results as each measurement is checked against its rule. The code goes through each threshold rule for patient measurements and looks up the matching patient value by measurement name. This lets it compare every expected measurement with its defined threshold. The code checks whether a measurement value is missing. If so, it records a warning that identifies the missing measurement and skips to the next one. This prevents threshold rules from being applied to missing data and keeps the evaluation process accurate. The code checks whether a measurement reaches a defined high threshold. If it does, the score increases by 1, showing that the condition was triggered. It also adds the related warning message so the user knows which threshold was exceeded. The code checks whether a measurement falls below a defined low threshold. If that threshold exists and the measurement is too low, it raises the score by 1 and adds the related warning message. This marks a possible issue and alerts the user to the breached limit. The code turns a numeric score into a simple risk category based on how many thresholds were flagged. A score of 0 means no threshold flags, a score of 1 means 1 threshold flag, and any higher score means multiple threshold flags. This makes the risk level quick and easy to interpret. The output shows the threshold score, indicating how many patient measurements met or exceeded the set limits, followed by a simple risk category based on that score. It then displays any warnings in a clear combined message. A final note reminds users that the thresholds support clinical judgment but do not provide a definitive diagnosis. The script screens patient measurements against clinical thresholds for temperature, oxygen saturation, and systolic blood pressure. Values that are too high or too low add to a score and generate warning messages, while missing values are also flagged. The final score classifies the patient as having no flags, 1 flag, or multiple flags. The output includes the score, category, and warnings, with the reminder that this is only a screening tool, not a diagnosis. Looped score logic. Looped score logic helps clinical scoring systems apply repeated rule checks consistently. It updates a patient's score as each criterion is evaluated, such as age, heart rate, or oxygen levels, without duplicating code. This makes complex scoring more structured, reduces errors, and helps ensure rule changes are applied reliably. Looped scoring often separates clinical rules from the scoring process by storing criteria as named items, such as symptoms or lab thresholds. The loop checks each rule, classifies findings like vital signs as mild, moderate, or severe, and updates the score. This makes the scoring logic easier to inspect and apply consistently across patients. Looped score logic makes clinical scoring tools easier to update and maintain as evidence or protocols change. It allows criteria to be added or removed without rebuilding the whole system. The key caution is to distinguish truly absent findings from missing data, so a skipped mental status check is flagged rather than treated as normal. This helps apply clinical rules consistently and safely. Python code, looped score logic. Looped scoring reuses clinical rules consistently, while dictionaries make the criteria easy to review. Warnings help distinguish missing data from normal findings. A patient's medical record can be represented with a dictionary, where each health metric is stored as a key and the patient's measurement is stored as its value. For example, it can include age and heart rate. This structure makes the patient's data easy to access, update, and use in later analysis. This patient record stores key assessment details. The breathing rate is 24 breaths per minute. Oxygen saturation is missing, and the patient is confused. The missing oxygen value will need separate handling, while confusion is recorded as a simple true or false value for the scoring logic. A rules dictionary stores clinical criteria for different patient attributes, such as age and heart rate. Each attribute includes a warning threshold and a point value added to the overall score when that threshold is met. For example, age over 65 adds 1 point, while heart rate over 110 adds 2 points. This structure makes it easy to manage and score multiple clinical risk factors. The code adds clinical scoring rules for respiratory rate, oxygen saturation, and confusion. A respiratory rate of 22 or higher and oxygen saturation of 92 or lower each add 2 points, while confusion adds 3 points. These rules help calculate an overall patient risk score from clinical data. The evaluation begins by setting the score to 0, so points can be added when patient data meets defined criteria. It also prepares 2 trackers, one for rules that are triggered and another for rules that cannot be checked because required data is missing. This separates confirmed findings from incomplete information. The program goes through each clinical rule and uses its key to find the matching patient value. This lets it check patient data against predefined criteria in a flexible, dynamic way. The code checks whether each patient record value is missing. If a value is missing, it records the related rule as unavailable and skips to the next rule. This prevents incomplete data from being used in scoring while keeping track of criteria that could not be evaluated. This part of the code handles oxygen saturation as a special case because it uses low threshold logic. It checks whether the patient's oxygen saturation is at or below the warning level set in the rules. If so, the rule is considered met, allowing points to be added to the total score later. This code checks whether the patient's confusion status matches the warning condition in the rules. Because confusion is a true or false value, the rule is met when the 2 values are the same. Unlike numeric checks, no threshold comparison is needed. This code applies high threshold rules for numeric patient criteria. If a patient's value, such as age or heart rate, meets or exceeds the warning threshold, the rule is considered met. When that happens, points are added to the total score to reflect the potential severity of the patient's condition. When a rule's condition is met, its points are added to the running total score. The item is also recorded in the list of triggered rules, so the system tracks which criteria were satisfied during the loop. The code demonstrates a looped clinical scoring example by printing the total score, the warning criteria triggered by the patient data, and any criteria with missing information. It ends with a reminder that the example is for education only and has not been validated for real clinical use. This script demonstrates a simple rule-based way to score patient data. It compares clinical values, such as age and heart rate, with preset warning thresholds, adds points when thresholds are met, and separately flags missing information. The output includes the total score, the triggered criteria, and any missing data, and it is intended for education rather than clinical use. Clear clinical reporting. Warnings and assumptions. Clinical reports should explain not only the result, but also its limits. Warnings identify possible problems with the input data or calculation, while assumptions state what must be true for the result to be reliable. For example, a kidney dosing estimate should flag missing or unusual values and note if it assumes stable serum creatinine. Without these clarifications, clinicians may place too much confidence in results that may not fit the patient's situation. Warnings in clinical reports should be clear, specific, and focused on why the issue matters. Rather than giving a vague caution, explain the uncertainty, such as a missing symptom entry or a patient outside a scoring tool's valid range. The aim is to make important limitations easy to notice without overwhelming the reader, so clinicians can make informed decisions at the point of care. Clinical reports should clearly state the assumptions behind calculations so clinicians can make safe, informed decisions. Measures like body mass index or pediatric dose estimates depend on simplified inputs, such as accurate height, weight, or a current child weight. Stating these limits helps clinicians confirm whether the calculation fits the patient and reinforces that calculations support but do not replace clinical judgment. Python code, warnings and assumptions. Clinical reports should clearly state calculation uncertainty, flag concerns about the data or interpretation, and explain assumptions that could make results misleading. This example defines a patient profile for later kidney function calculations. The patient is 84 years old, weighs 52 kilograms, and has a serum creatinine level of 1.1 milligrams per deciliter. The creatinine level is marked as not stable, which will be important when checking assumptions and warnings. The setup defines age validation limits, allowing calculations only for patients between 18 and 80 years old. It also prepares separate places to record assumptions needed for valid results and warnings about any data validation concerns. Before using the estimate, we assume the serum creatinine reflects stable kidney function and that the patient's current weight is recorded in kilograms. These assumptions help keep the calculation reliable and standardized. The result should support clinical review, not drive automatic dosing decisions, so clinical judgment remains essential. The rule checks whether the patient's age is above the allowed maximum. If it is, a warning is added to show that the age falls outside the range where the calculation is typically validated. This helps flag possible limits in the result's accuracy. The code checks whether an adult patient's weight is plausible by flagging values below 40 kilograms or above 200 kilograms. If the weight falls outside this range, it adds a warning, so later calculations use more realistic and reliable data. If creatinine is not stable, the system adds a warning that estimates may be misleading. This flags a potential concern for the clinical assessment. A simple estimate of kidney function can be calculated using age, body weight, and serum creatinine. The formula adjusts for the expected decline in kidney function with age, the effect of body size, and the creatinine level as a marker of filtration. The result is an estimated clearance rate in milliliters per minute, giving a rough educational measure of kidney function. The code uses estimated kidney clearance to choose a dosing review category. If clearance is below 30, it marks that a renal dose review is likely needed. If clearance is 30 or higher, it assigns a standard review category, meaning special kidney-based dose adjustment is typically not indicated. The report presents key clinical calculation results in a clear format. It shows the estimated kidney clearance in milliliters per minute, gives the dosing category to guide renal dose review, and reports any warnings or states that none were generated. It also lists the assumptions behind the calculation so the results can be interpreted in context. This script estimates kidney function from a patient's age, weight, and serum creatinine using a simplified clearance formula. It first checks whether the patient data are within expected ranges and whether creatinine is stable, adding warnings if needed. The result is used to decide whether the patient needs a renal dose review or a standard review, while also reporting the estimate, warnings, and calculation assumptions. Assumptions and limitations. Clinical calculations are only valid under certain assumptions, so those assumptions must be made clear. A score or risk category should state the patient and data conditions it depends on, such as stable kidney function or measured height and weight. If these limits are hidden, results may seem more certain than they are and could be misused. Clear assumptions support safer and more reliable clinical decisions. When reporting clinical calculation limits, clearly state what the result can and cannot show. These tools can summarize risk or guide attention, but they do not capture the full complexity of a patient's condition. Scores for frailty, dosing, or sepsis still require clinical judgment and further evaluation when needed. The calculated result should be kept separate from the final clinical decision. Clinical calculations should always be reported with clear assumptions and limitations, because results such as risk levels or normal ranges can appear more certain than they are. Their reliability depends on data quality, timing, and whether the patient fits the intended use. Specific warnings about missing or outdated data help clinicians interpret results carefully and use them appropriately. Python code. Assumptions and limitations. Clinical reports should clearly state the limits of any calculation. Warnings help reveal assumptions that might otherwise stay hidden, making BMI reporting more responsible. A patient record is represented with a dictionary that stores key details as key value pairs, including the patient's name, age, and height. This structure makes the data easy to access and update throughout the code. The patient's weight is recorded as 92 kilograms for a later BMI calculation. The measurements may not be current, so the BMI could be less accurate. The patient is not pregnant and is not pediatric, so standard adult BMI categories apply. The process begins by setting aside a place to record any warnings about the patient data. The patient's height is then converted from centimeters to meters so it can be used to calculate BMI. Finally, BMI is found by dividing the patient's weight in kilograms by the square of their height in meters, giving a height and weight-based estimate of body fat. The code adds warnings when BMI results may be less reliable. It flags patients under 18 because adult BMI categories may not apply to children. And it also warns when height or weight was not measured today because the data may be outdated. These checks help make assumptions and possible inaccuracies clear. The code adds warnings when BMI results may be unreliable or invalid. It notes that pregnancy can make BMI less accurate, and it checks that the patient's weight is greater than 0. These safeguards help communicate when the BMI calculation may not be clinically meaningful. The code classifies an adult's BMI by checking it against standard ranges in order. A BMI below 18.5 is underweight, below 25 is normal, below 30 is overweight, and anything higher falls in the obesity range. This ensures each BMI value is placed into one clear category. The report begins with a clear clinical report header, then shows the patient's name from the patient information. It calculates the patient's BMI, presents it to one decimal place with kilograms per square meter as the unit, and adds the BMI category, such as underweight or obesity range, to give a quick health assessment. The code makes clear that it is using adult BMI categories to interpret the calculated values. It also notes that BMI does not measure body composition, so its results have important limits. Finally, it sets up a warning section to flag any issues or considerations found during the BMI calculation. The code displays warnings in a clear format by printing each warning message with a dash. If no warnings were triggered, it prints a default message saying there are no additional warnings. This ensures the user always receives feedback about the warning status. This script calculates a patient's body mass index using their height and weight, then assigns a standard adult category such as underweight, normal, overweight, or obesity. It also adds warnings when the result may need caution, such as when the patient is under 18, pregnant, has outdated measurements, or has an implausible weight. The final report gives the patient's name, BMI value, category, assumptions, and any warnings, or states that no warnings were found. Explain limitations clearly. Clinical reporting should explain what a score means, not just present the number. Risk scores, such as those for stroke or sepsis, depend on inputs like age, lab results, and other patient data, so their reliability depends on the quality of that information. If key data are estimated, outdated, or uncertain, those limits should be stated clearly. This transparency helps prevent misinterpretation and makes the result more useful for communication. Clinical report limitations should be stated clearly and tied to their practical impact. Note when a score relies on an estimate or when a tool is not validated for a patient group, and explain how that may affect reliability, such as dosing accuracy or risk interpretation. This helps clinicians judge whether to trust the result, repeat the calculation, collect more data, or seek expert input. Clinical calculations should be presented with clear limitations because they support but do not replace professional judgment. Their results need to be interpreted within the full clinical context, especially for complex or unusual patients. Transparent reporting helps clinicians understand the basis and uncertainty of a calculation, reducing overconfidence and encouraging appropriate follow-up. Python code. Explain limitations clearly. Clinical reports should clearly state the limits of their calculations, so results are not interpreted with too much confidence. Including warnings supports cautious, responsible score descriptions. A simulated patient record is created as a dictionary containing age, weight, and creatinine level. The patient is 82 years old, weighs 68 kilograms, and has a missing creatinine value. This structure makes the patient data easy to use later for risk scoring or warning generation. We store key calculation assumptions in a simple record, including an estimated creatinine value of 1.2 and a note that the source is estimated. This documents that the value was inferred rather than directly measured, helping clarify the limits and reliability of the resulting risk score. A simple rule-based risk score begins at 0 and adds 1 point if the patient is 75 or older. This captures age as a basic clinical risk factor. The rule checks whether creatinine is at least 1.5. If so, it adds 1 point to the risk score, reflecting that higher creatinine increases the assessed risk. The code assigns a concern category based on the score. A score of 2 or more is labeled higher concern, while lower scores are labeled usual concern. This provides a quick way to judge the risk level tied to the score. The process creates an empty warnings list to record cautionary notes about the patient data. If the patient's creatinine value is missing, it adds a warning that an estimated value was used, making the calculation assumption clear. The code checks whether the creatinine value was estimated. If so, it adds a warning that renal risk interpretation may be less reliable. The code flags patients over 80 by adding a warning to the report. This highlights that advanced age may require a more thorough clinical review by healthcare professionals. The report begins with a clinical calculation header, then presents the patient's score and risk category for a quick summary of the result. It also notes that creatinine was assumed to be 1.2 milligrams per deciliter, and then introduces limitations and cautions that may affect how the result should be interpreted. The code uses enumeration to go through the warnings while keeping track of their positions, starting the count at 1. It then prints each warning with its number, making the messages clear, concise, and easy for the user to follow. The script ends by reminding users that the calculated result is only decision support, not a final diagnosis. It cautions that the score should be interpreted with clinical judgment rather than used on its own. This script creates a short clinical decision support report by estimating a patient's risk from age and creatinine level. Because the creatinine value is missing, it uses an assumed estimate, which can raise the risk score if it is high, and age can also increase concern for older patients. The final report labels the result as either higher concern or usual concern, notes any assumptions, and includes warnings when the estimate or advanced age may limit confidence. It emphasizes that the result supports judgment but is not a diagnosis. In this lecture, you learn to implement validation checks for missing, out-of-range, or inconsistent medical inputs. Create rule-based clinical scores using conditionals, loops, and dictionaries. And report calculation results with warnings that clarify assumptions and limitations. In the next module, Module 4, we will go over none. Thank you for your attention. See you all in the next lecture.